Welcome to this PCR webinar on transcatheter left atrial appendage closure, current and future indications, and this in collaboration with the European LAA Closure Club. I am Ole de Bakker, working in Rigshospitalet Copenhagen in Denmark. So as a first, let me introduce you to the learning objectives of this PCR webinar. So this is to learn about the evidence for left atrial appendage closure in 2025. This is based on current guidelines and indications. Also, to know what it requires to plan, perform, and follow up a patient undergoing left atrial appendage closure, and this in current clinical practice. And also, we're going to discuss the future directions of LAA closure with recent and upcoming trials. So, before giving the hand to the speakers, I want to introduce you to the panel I'm surrounded with. I have some experts here on my side. I have Philippe Garot from Massy in Paris. I have Marek Grigir from Poznan in Poland, and online Xavier Freixas will join us. Xavier is an operator in Barcelona in Spain. So before introducing you Philippe Garot, I also want to motivate you and encourage you to really post questions using the chat function. So Philippe, with this I want to introduce you, and you are going to talk about the current indications for transcatheter left atrial appendage closure.
Absolutely, thank you, Ole. And as you know, left atrial appendage closure is a stroke prevention procedure for patients with atrial fibrillation. And we have to say that today in Europe, the use of left atrial appendage closure is not so liberal. It's restricted to patients with AF and a contraindication to long-term anticoagulant treatment to prevent ischemic stroke and thromboembolism. And as you can see, it's a 2B class of recommendation level of evidence C in Europe. On the other hand, in the US, we have to mention that the guidelines have been improved recently thanks to new data and coming data, and now it's 2A in the US for patients with a high risk of stroke and contraindication to oral anticoagulants, and it's even a 2B in patients with a high risk of major bleeding on anticoagulants. Even non-bleeders can benefit from the procedure. And they mention in the US that patient's preference or patient choice is part of the strategy with this, which is really, really interesting to mention. Having said that, I think we have to say that we have now a lot of evidence that LAAC is a good procedure to prevent stroke, and these data come from pivotal trial that we had since years in patients who are eligible for oral anticoagulants. And you can see here in this plot from PROTECT, PREVAIL, and PROACT 17, and now we have new data coming from OPTION in the same population of patients who are eligible for anticoagulants, that these patients have a similar protection against ischemic stroke, and they may benefit from the procedure because, of course, you can interrupt anticoagulants, and then you have much less non-procedure related major and life-threatening bleeding, and especially much less hemorrhagic stroke and intracranial hemorrhage. So this is one of the benefit of the procedure, that you can stop, interrupt anticoagulants in these patients. And then another point that is very important is from the beginning, like 22 to 23 years ago, we have now a very safe procedure. As you can see here, this data from the American registry last year, and they published a very, very low rate of complications. So now the procedure is mature, and I think we can go on, and we will see, for example, this case done in my center a few days ago. This is really a routine, a standard case that we do. It's a patient, 80 years old, male. He was referred for LAAC by his neurologist because of a new diagnosed cerebral amyloid angiopathy, and the neurologist considered this pathology to be a formal contraindication for long-term oral anticoagulants. Few words about the prior clinical history of these patients. He had episodes of decompensated heart failure. He had COVID with myocarditis a few years ago. He has a permanent AF, of course. His risk factors are hypertension, hypercholesterolemia, and type 2 diabetes mellitus. On top of cardiovascular history, he has a Parkinson's disease, and he is really disabled, and new evidence of intracranial bleeding revealing this cerebral amyloid angiopathy. So medical therapy, I will not go into details. There are treatment for hypertension, treatment for Parkinson's disease, but most of all, apixaban was discontinued because of this intracerebral bleeding. Lab investigation showed nothing special with a normal renal function. And finally, the patient's risk assessment, we have a SHATS-VAS score of 5. You can see here, so a very high risk of stroke. By SHATS-VAS is 6.7% risk of stroke events per year. But he also has a high bleeding risk because of age, hypertension, and predisposition to bleeding with this cerebral amyloid angiopathy and risk of fall. So he has a contraindication to all anticoagulants. So the heart neuro team decision was to decide for LAAC. So as we do for all our LAAC patients in my center, we did a CT for this patient, and you can see the interest of having a CT. We have a multiplanar reconstruction of all the heart, and we are focusing now on the left atrial appendage. And you can see that we can have the appendage in several projections. We can measure the ostium or the landing zone. We can see the depth of the appendage. We can see a lot of things with CT. We can see the relationship with the surrounding structures, especially the mitral annulus and the left upper pulmonary vein. And interestingly, we had measured the landing zone for the procedure at 22 by 35 millimeter. You can see that using the Trimancio software that we use, we also were able to plan the transeptal puncture that was, in this case, inferior and posterior to get the best alignment with the appendage and to ensure for good coaxiality for the procedure. So one word about the LAAC classification that we recently published in Neurointervention. You can see that the LAAC classification has some, I would say, complexity characteristics that are categorized by the ostium, the landing zone, the anatomy, the axis, and the contraction of the appendage. And for this specific case, we have a straightforward, I would say, simple case, just score 0. So we do not expect to have a very complex procedure. We expect to have a straightforward procedure again, and a good result with a very low risk of complications. So we had, for the procedure, TEE on the table. The patient is under general anesthesia, and we use routine 3D TEE, not miniaturized in my center, on a regular basis. And we had the same measurements compared to CT, a little bit underestimated, which is quite normal with the two different modalities. But we were ready to go for the procedure because we ruled out the presence of a thrombus into the appendage. And then you can see the transeptal puncture. For left atrial appendage closure, I think it's important to say that we plan to have an inferior puncture in most of the case, or in all the case, I would say. And in most of the case, we try to be posterior to have a good access with the left atrial appendage. In some cases, with a special anatomy that have a retroverse orientation, we may have an anterior, mid to anterior punction to be sure to have the best alignment. And then you can see here on this moving image that we have the delivery sheath of the device inside the left atrial appendage. It was not so difficult to reach the appendage, and you can see that there is a pigtail into the delivery sheath at the end, at the tip of the delivery sheath. And then we removed the pigtail and we went with the device that you can see here. This is a Watchman Flex 35. So you can see that we have different sizes of the device, 20, 24, 27, 31, and 35, depending on the measurements that you have on CT or TEE. And this patient has expected as a quite straightforward procedure with this device obtained. So we have to be sure that the device is first stable. So we do some measurements of the compression. We just check about the position of the device. We do a tuck test to be sure that the device is well anchored in the left atrial appendage. And when we see that the position is nice, that there is no risk of migration, that there is no leaks around the device, so we can release the device in this position. And this is what we get. You can see here from TEE, we had a proximal position. You can see the different projection of TEE, and there was a good compression and no leaks, so we released the device in this position. So post-procedure was even free. There was no pericardial effusion on transthoracic echo. The device was in place, and we gave the patient aspirin 100 milligrams for 3 months because of cerebral amyloid angiopathy. And this patient had a CT at 3 months, and you can see here that the appendage was completely occluded and sealed with no contrast into the appendage. We had a very low grade of hypoattenuated thickening, less than 3 millimeters, smooth surface, no DRT, and then we interrupted aspirin in this patient.
Mm-hmm. So let's discuss this further. Thank you for this, Philippe. So Marek, any comments on Philippe's presentation?
Yeah, Philip, thank you very much. It was an excellent example of the everyday clinical practice in most of our labs. However, I'd like to come back to one of your slides. You mentioned the LAAC classification. It's a classification which was just published recently. What do you think? What are the expectations, and how we should approach to that classification in everyday clinical practice? Should we use it before the procedures? It should be used only in, let's say, high volume centers, low volume centers. How you interpret the data? Moreover, you mentioned that based on that classification, that case is simple.
Yes, absolutely. Thank you, Marek, for this great question. I really think that the classification is really useful. In the past, we have another classification that was not really useful for the implanters, but this one, you have like anatomical and functional characteristics of the appendage of your patient. So you may anticipate the complexity of the procedure, and you may also anticipate the risk of complications. So what I think really is that if you have some, like complex characteristics in your patient, you may improve, for example, the level of imaging that you have before the procedure. For example, if you do a TE and you say, okay, this is a case with a retroverse, with an early band, or some very important, I would say, very large appendage or very shallow appendage, something like that, then I will encourage you to do a CT, because you may have a second imaging procedure or imaging modality to be sure that the procedure is feasible or not. Or, for example, for you, Ole, I know that you are using ice during the procedure, yeah. And of course you're an expert with ice, but if you have a very complex case and you say, okay, usually I use 2D eyes because, yes, 3D now is available, but it's very expensive. So I would say that maybe for a very complex case, you may benefit from a 3D eyes, and then you're sure you will have a better, I would say, imaging assessment of your device.
Mm-hmm. Yeah. So, Philippe, also the case you show, so this is a man who has very high stroke risk. He has not had a bleeding before, but he has an increased bleeding risk because of his cerebral amyloid angiopathy. But I see you put him straight after the procedure, just on 3 months single antiplatelet aspirin. How do you do that? Is this your routine for all your patients? Do you do this taper to the outcome you obtain during your procedure, or how do you do this?
That's a really critical question, and I have to say that we don't have evidence on that topic. We don't have, I would say, single antiplatelet therapy. Aspirin per se is not the routine regimen that has been used in pivotal trials. They usually use DAPT or short-term anticoagulants to avoid, to decrease the risk of device-related thrombus. But yes, in clinical practice, we are using for some patients like lighter regimen, like single antiplatelet therapy or low-dose anticoagulants. And I have to say that not in randomized trial, but in observational registry, we have good results with low rate of DRT. And we have to think about the patient, and we have to think about the bleeding risk. And I think it's always individualized and the result of a good discussion between the implanter and the physician who is referring the patients. And the neurologist said, no, cerebral amyloid angiopathy, I don't want this dual antiplatelet therapy. It's not serious.
It almost gives the same bleeding risk as a
yes.
low-dose DOAC, for example. And indeed, the population we're treating in Europe are mainly still bleeders or high bleeding patients. So probably double antiplatelet therapy still exposes these patients to quite a high bleeding risk, yes, indeed. So, okay, good.
So, thank you very much. And now it's my pleasure to introduce you, Ole, to I would say talk about the patient pathway. What do we really need before, during, and after the procedure?
Yeah. Yes, indeed. I'll try to give in the next couple of minutes in a nutshell a little bit what do we really, in real practice, what do we really need before, during, and after the procedure if you, for example, start a program. Well, first, what do we really need before the procedure? Well, first, we need, of course, a patient. Yes, we need a patient with atrial fibrillation. Clearly, this is a therapy, a preventive therapy, stroke prevention therapy for patients with atrial fibrillation, and they must have at least a CHEST-VASc of 2 or more. Yes, but typically the patients we are treating are these patients that are the two ends of the spectrum. You have these patients with atrial fibrillation. They can have a very high thromboembolic risk, like the patients with a high CHEST-VASc, like your patient with a CHEST-VASc of 4 or more. Or we have, on the other spectrum, we have patients with a very high bleeding risk, a prior major catastrophic bleeding, intracranial bleeding, gastrointestinal bleeding, or just patients with a high elevated risk. They haven't bled yet, but we know their has bled risk is, for example, 3 or more. So these are the patients we typically are treating. And so we need a proper patient, a good patient selection. We need also cardiac imaging. That's obvious. Typically, the standard is transesophageal echocardiography. That's mainly to rule out thrombus in the appendage, also to have an understanding of the overall complexity of the structure, of the morphology of this appendage, and also of the sizing, yes. But there is also more and more use of cardiac CT indeed, and especially if you have a suspicion of a complex appendage, I would strongly indeed encourage to do that, yes. So, and why is this? Why do we need this imaging? Well, LAA anatomy can be highly variable and actually very complex. You see here, these are a couple of anatomies also described in this new LAAC scoring system. So you can have a long comedon ridge, you can have a very angulated appendage, you can have multiple lobes, you can have a reverse chicken wing kind of, you can have a shallow, you can have a very wide open tapering ostium. So this anatomy can be highly complex and highly variable, and that's why preparation of such a procedure, this is really the ticket to success, I would say. What imaging do we use? Well, I think over the last couple of years we come to realize more and more that we need 3D imaging. It's a highly complex structure, so whether you do 3D TEE or 3D multiplane reconstruction on cardiac CT, I think both imaging modalities are performant and have proven that they are solid. But it's important really that we do this multiplane reconstruction. It helps to understand this complex 3D structure, and especially also our sizing will be more precise. Yes. Then what do we need during the procedure? Well, during the procedure, I would say we need definitely intraprocedural imaging. We all use fluoroscopy, of course. We need echo guidance, whether this is with TEE, mini-TEE, eyes, 2D, 3D eyes. I think there are different pathways that can be used depending on what you're used in your center. And then the procedure, for me, it's almost a procedure which is equally important, the transeptal puncture, as the device implant. It's almost 50-50 for me. Your transeptal puncture is a key for success. If you have a good coaxiality with the appendage, you typically have a smooth, easy procedure. You will have a good outcome. And then the device deployment implantation itself, well, we should, of course, do everything to keep this as safe as possible and also patient-tailored. So we can do device choice. We should do the correct size selection of this particular patient we have to treat. So what we need is, as you see here, to come to a final proper, successful LAA closure, we need a good pre-procedural planning. We need a proper device compression because the devices we currently are using are mostly relying on a good compression. There will in the future maybe also come the devices that are not depending on device compression, but we're not there yet. We need the proper coaxiality of the device. We need also a proper depth of implantation. If we go for a too deep implantation, we risk device-related thrombus, as our friend Xavier Freixa has shown in a paper. If you go for a too proximal implant, we risk maybe leaks. We also risk, in the worst case, even device embolization. And then last but not least, we also need post-procedural and the correct patient-tailored antithrombotic therapy. So with that, what do we need after the procedure? We need indeed a patient-tailored antithrombotic therapy, and this is something new. I think if we talked about LAA closure 5-8 years ago, this was routine. Every patient was put on, either in the US, was mostly oral anticoagulation or vitamin K antagonist in that time still for 45 days. In Europe, more double antiplatelet. I think nowadays we see more a change and a patient-tailored treatment. Some can still have the double antiplatelet, more and more adoption also of immediate single antiplatelet therapy after the LA closure. There is also some schools or some centers using the low-dose DOAC for 3 months or another combination. But at least I would say single antiplatelet for a minimum of 6 months is kind of typically the minimum set for these patients undergoing LA closure. And then finally, we need some imaging follow-up. This can be either done also with TE or cardiac CT. What we want to rule out is we want to first see whether the device is in place, nice in place, in good position, whether there are no important peri-device leaks, and thirdly, whether there is no device-related thrombus. And this imaging is done between 45 days to 6 months. Many centers have moved from this 45 days to 3 months, so that's also a very reasonable time point to do your imaging.
Ole, thank you very much. I think that it was an excellent overview of the patient pathway. However, I'd like to come back to your slides. I will maybe start first with what we have to do before. And I have 2 questions. One, do we really need imaging before, or imaging on the table, it's completely enough? And the second one, you mentioned TEE and CT.
Yeah.
What is the preferred option? How you approach it in your lab? In your lab, I know it's mostly CT, but for our viewers, how they should approach? Is it necessary to have CT or?
Well, necessary, no. I mean, sure, this LA closure is done in many centers without CT. So first, your question, do we need really pre-procedural imaging or not? Can we just do it, not immediately imaging on the table? Of course, everything can be done. It can be done just with imaging on the table. But I would say, look, this is a structural heart intervention. What is the success of, for example, TAVI? The success of TAVI, why it's become so safe, so efficient procedure is because we go into that procedure extremely well prepared. We know the anatomy in and out. And I think it's the same for LA closure. This is even a more complex procedure to do, to be honest, than a TAVI very often. So if you know this anatomy, you know everything in and out, you make your procedure just slick, easy, safe. I think so. That's why I would advocate really for pre-procedural planning. And then whether TE or CT gives you the same, well, it kind of, if you do proper 3D imaging, TE or CT gives you the same understanding of the structure, of the sizing. But I would say still, CT can give you a couple of additional points. For example, the optimal implantation view. You can calculate this really on CT, where REO, so many degrees, caudal or cranial. This is not possible on TE. You can also estimate your best transeptal puncture sites, although on TE, you could potentially also have an assessment of that. CT can also be used for computational modeling. You can also do fusion imaging of it. So it still gives you a little bit more edges to the imaging. But anyway, to me, pre-procedural planning and imaging is key.
Okay.
Ole, we have a question from the chat, and Hamid. Hamid is an implanter, and he asks you, how do you select the best projection for the landing zone? How do you select with your C-arm where you are in the best, I would say, situation to get the best result?
Yeah. Look, indeed, that's a very good question. So if you determine your landing zone or ostium, depending on which device and what you have to measure, if you do this, for example, in a three-dimensional program, you see, you define this landing zone or this ostium. What do you have to do? Why do we have to go REO typically? Well, because our appendage goes anterior. Yeah, so if you go REO, you don't see the foreshortening. Yes, you want to elongate. You want to see the full length of your appendage. So that's what you do. If you mimic your 3D reconstructed image on CT, you can see REO going. Some appendages are enough to go REO 30. Some you have to go 40. Whether you have to go cranial or caudal, that's the difference. What I want is as good as possible separation from the LA and the left atrium. Yes, if this would be my left atrium and this would be my left atrial appendage, I want a projection where these two structures are isolated. I don't want to have a projection where there's a lot of overlap cranial or caudal. I want to have them isolate it as good as possible. So that's what we aim for, yes? And that means typically also there, if you have a circle defining the ostium, where your circle of defining the ostium, you don't see any parallax. You look in the plane of the ostium, and that accords typically where you have best the isolation of the left atrial appendage and the left atrium.
And that's an advantage of pre-procedural
Yeah,
planning.
because look, this is in some patients, it's best cranial 20. In others, you clearly see if you go cranial 20, you have plenty of overlap. It doesn't serve to give there an injection with contrast. It's spill of contrast. So you can really diminish your projections and contrast injections if you do that during the procedure.
Marek, you have another question?
Yeah, maybe I will come back. I ask about what's before, and what about the intraprocedural imaging? What should be the choice? TEE, eyes, how you approach that?
Well, there I'm not very outspoken on. I think really that's depending a little bit on your pre-procedural planning and imaging too that you use. Look, I use, for example, 2D eyes easily in my procedure. It's not good enough to give you 3D imaging intraprocedurally, so then I'm a little bit more handicapped intraprocedurally, but that means that I need top-notch, I need the best possible imaging pre-procedurally. I need my 3D CT up front, but I think intraprocedurally you typically have enough with even 2D echo imaging, but then you're reliant on a very good pre-procedural 3D imaging. Otherwise, I would definitely advocate for 3D imaging too. Nowadays it's possible with mini TE even, mini TE 3D, and the fluoroscopy you will also use with your optimal implantation view. Yeah.
And what about post-procedural imaging?
Yeah.
You mentioned about the TEE and CT. And what is the value of these two methods? How you should interpret the data from that if you, for example, see a leak?
Yeah, it's a good question. It's a good question because, look, I mean, you can do TE or CT for follow-up imaging, and you more or less can see the same, but there are differences, important differences. Look, I think on TE, what you look for and what you screen for is device-related thrombus, and whether there is a leak around the device. You can nicely screen for that, and typically if a leak is 3 millimeters or more, we start to question, should we do something additional here? On CT, on the other hand, what you can have on CT is, especially if you scan relatively early, 45 days, 3 months, you can see contrast going into the appendage. We call it a patency, but without a peri-device leak. So it's not that easy. An assessment on CT, you have to be careful to over-interpret patency of contrast going into the appendage. Why? Because very often in many appendages, this appendage closure device is not endothelialized yet. There can be going some contrast through the fabric of the device still. So you really have to, in a way, make a 3D reconstruction and look, is there a leak around my device on CT? So you have to be careful with over-interpreting contrast going into the appendage on a cardiac CT. Yes?
And I think it's really important to mention because there's no clear relationship between patency by CT and clinical outcomes.
Exactly. There's only been associations been made with clinical events if you see clear peri-device leaks, such as on TE, but with patency on CT, there has been no association with increased thromboembolic events, for example. That association has not been seen. So that's indeed an important point, Philip.
And Ole, that follow-up assessment, CT or TE, when exactly you performed it in your lab? 45 days, 3 months, 6 months?
Yeah.
What you advocate?
I typically, as said, I think we move more and more to the 3 months. We found out that 45 days is definitely too early most of the time. So I think more and more centers in Europe are moving to this 3 months time point instead of the very early 45. Or some centers are also doing 2 months, I heard. So, but I think, yeah, it's more and more to the 3 months, some even 6 months. But that maybe I think it's almost too late. You also don't want to miss on the device-related thrombus. So that's the point I do. So with that, we have to move on indeed. And Marek, I invite you to present about the option AF. Will this really change my or your practice?
Okay, Ole, thank you very much. And I have privilege to talk probably about one of the most important, I'm sure, the most important trial last year in the field of the LAA closure. First, why that trial is so important? The trial is important because it tried to answer to very important question. you have a patient after ablation of atrial fibrillation. And as you know, in current guidelines, these patients, if they have CHA2DS2-VASc over 2, these patients should be on oral anticoagulants until the end of their life. However, many of these patients do not want to continue oral anticoagulants treatment. So the question which was raised in that trial was, if this patient has option, if they can be treated with oral anticoagulants, or instead of that, if it's possible to close the left atrial appendage in that subgroup of patients. So the trial, as you can see here, was published in November last year. And what was the design of the trial? As you can see, it's a trial of almost 1,600 patients, which were randomized patients after AF ablation, which are randomized to continuous treatment with oral anticoagulants as is in the current guidelines, or to the second arm in which there was AF ablation plus LAA closure. And that LAA closure could be done as a concomitant procedure, so just as a one-step procedure, or it could be a sequential option. So first there was an AF ablation, and after 3 to 6 months, there was a second procedure, which was the LAA closure. And there were primary efficacy and primary safety endpoints. The primary efficacy endpoint was to show if such a treatment with the LAA closure is non-inferior with regard to stroke, all-cause mortality, and systemic embolism. And there were also primary safety endpoints just to show if such an approach is superior to the traditional approach with oral anticoagulants. So it was the main design of the trial. As you can see, as I mentioned, 1,600 of patients were randomized. What is important to mention is that these were patients with CHA2DS2-VASc something about 3.5, however, with low bleeding risk, 1.2. Some of them was patients after prior stroke, majority of them with paroxysmal atrial fibrillation. And the LAA closure was done as a concomitant procedure in 40% of the patient and as a sequential procedure in almost 60% of the patient. The first important message is from the trial that the LAA closure was successful in almost 99% of the patients. So it was successful as a Pinnacle Flex pivotal trial, which was published previously. Then, when looking at the primary effectiveness endpoints, you can see that the trial meet the primary efficacy endpoints. So, other words, Watchman treatment with Watchman device was non-inferior to traditional treatment with ablation and continuous oral anticoagulants. What is worth to mention that is probably the first trial in which the ischemic stroke was exactly the same in both group of patients, because in the past, as you remember, there were always questions that by closing LA, you are able to reduce the number of hemorrhagic stroke by increase of ischemic stroke. However, here, in the controlled randomized trial on a huge number of patients, you can see that there is no difference. When you are looking at safety endpoint, the trial meet the primary safety endpoint, so non-procedural major bleeding, at 3 years with Watchman's Flex was statistically superior to oral anticoagulants. And in fact, you observed a 56% relative risk reductions of these major and clinically relevant non-procedural bleedings. However, there was also questions that maybe these patients are not bleeding after, but there is a high risk of bleeding during the procedure. However, if you look at the second primary safety endpoint, if you include even procedural bleeding, you still observe a significant reduction and significant signal of the safety endpoint from the LAA closure instead of oral anticoagulants. What is also interesting is to look at the subgroups of patients, and you can see that non-inferiority and superiority of Watchman flex for the primary endpoints, both for efficacy and safety, were absolutely consistent in all subgroups of patients. And there was also a second publication just a few weeks ago, a second publication from the trial which looked at concomitant and sequential cohorts of patients. So in other words, is it better to do these two procedures as a one step, as a concomitant procedure, or in two steps as a sequential procedure? And you can see here, just in 2 slides, that regardless if you are doing it as a concomitant or sequential procedure, the results are exactly the same. So here, for the concomitant subgroup, as you can see that the primary efficacy is exactly the same as for the whole subgroup. And non-procedural bleeding is also significantly less. It's almost 44% reduction in bleeding in that subgroup of patients in which the Watchman flex was used instead of oral anticoagulants. And if you look at the sequential subgroup of patients, so sequential as just I'm reminding that these patients were closed 3 to 6 months after ablation procedure, the results are exactly the same. Primary efficacy, there is no significant difference. Maybe there is even a trend that LAA closure was more efficacious. And regarding the safety endpoints, as you can see, also bleedings in that subgroup of patients is significantly less after the LAA closure. So in conclusion, the trial showed us that we have really an option for our patients, that if you have a patient after AF ablation, our patient has now an option. If they want to continue oral anticoagulants, or maybe instead of oral anticoagulants, they want to have the LAA closed, and after a short period of antiplatelet, anticoagulant therapy, they may stop these drugs and remain without these drugs, and it's still a successful way of treatment. Thank you very much.
Thank you, Marek, for the great overview of this groundbreaking trial. It's really an important trial, as you mentioned. I have a first question for you about the primary endpoint, because it's so important in a trial. First, efficacy. You mentioned that there's a similar risk of ischemic stroke, but also bleeding stroke or intracranial hemorrhage. And as you mentioned, it's more a comment than a question, because you answered the question already. It's so important that we have new data on that, because we give with new data, with new patients, and especially in the context of ablation, this new insight, which is quite new for the field and for the procedure. And my question is about safety. I was surprised when the trial was presented recently that there is a so important difference in terms of bleeding between patients with anticoagulants and patients with Watchman. And I have to say why I was surprised, because usually we see this kind of difference in high bleeding risk patients. And we know that we are treating patients with high bleeding risk with LAAC, because we want to avoid for bleeding, major bleeding, life-threatening bleeding. And here you mentioned 50 to 56% reduction, but the Hasbled score is 1.2. So these patients are low bleeding risk. Can you explain?
Yeah, it's a very good comment. Yeah, in fact, in the trial, Hasbled, as you remember, was 1.2 in 2 subgroups. So in our, let's say, common way of thinking is that these are patients with very low bleeding. However, the trial showed that even in that potentially low bleeding risk, when being on oral anticoagulants, the bleeding is not so low, because as you remember from these curves, it's a few percent even in these potentially low bleeding risk patients. So maybe in the randomized trial with oral anticoagulants, you observed the almost 3% of significant or major bleeding in 1 year. But there are several registries, several smaller trials showing that the bleeding is probably higher. And that trials show exactly the same, that maybe even in these patients with potentially low bleeding risk, the bleeding is higher. So then again, a signal that maybe if you are able to offer your patient something else, I mean the LAA closure, maybe it's a proper way of doing that for our patient.
But Marek, because there's so much focus here indeed, and I think that's justified on the bleeding. So the oral anticoagulation treatment. So if I understand well, in the group which underwent appendage closure, there was still a 90-day after their appendage closure, because the sequential, if it was sequential, was first ablation and then LAA closure, yes? Not the other way around, yes? Okay, so then from the time of LAA closure, there was still an obligated 90-day oral anticoagulation therapy, correct? Yeah. So do you think this is really a must? How will this spin out in real world? I mean, in real world practice, do you think because we were just talking about, we go maybe for less, like single antiplatelet, some double antiplatelet, or at least more single antiplatelet. Do you think that 90-day oral anticoagulation, it's a must, or is it depending on whether it's sequential or concomitant? What's your take on that?
Yeah, it's very good comment. Yeah. So in concomitant group of patients, of course, there was a requirement for oral anticoagulation because that oral anticoagulation is associated with ablation. Yes, so it's a must. However, in that sequential group of patients, maybe in the future, we may consider that instead of these oral anticoagulants, we will use, as it's nowadays in clinical practice, DAPT or even single antiplatelet therapy. In the trial, it was different. However, definitely, there is probably a way that we may rethink in the future that in that subgroup of patients, after all anticoagulants, LAA closure, and then maybe just simpler protocol for protection of the thrombus development of the device. I definitely
you see
think
the stroke risk is actually really low, yes? It's 1.7% or something, whereas the bleeding is still a larger problem than the stroke problem, but it's probably finding the right balance there, and that we need future trials for that.
Absolutely.
Yeah.
Thank you, Marek. So we had a great overview of what we now have for the present and the recent past, and now it's my pleasure to invite Xavier Frexa from Hospital Clinic Barcelona to talk about the future. Xavier, please tell us about the coming trials, what to expect from them.
Hi, Philippe, and thank you to everybody. Thank you, Ole. Thank you, Marek, for the great presentations. Actually, I have to admit that it's been quite challenging to sum up, all the evidence and all the studies that are coming, because there's a lot. In any case, I would like to start my presentation highlighting two important points. The first point, it's something that probably you already know, but it's always good to remind that AF is extremely prevalent. As you can see, it affects 2% of the worldwide population. That means that more than 30 million people are suffering, from this condition. And second point, that the prevalence in people older than 85 years old, it's almost 20%. That means that a very fragile population, old and fragile population, will be presenting, atrial fibrillation. That means that we can, expect and anticipate some future problems. And one thing that is surprising is that, if we see the current penetration of the left atrial patient occlusion among these patients, we can see that it's less than 2%. I cannot believe that 98% of the patients, suffering from atrial fibrillation have no problems. And actually, this picture, like the Roman Empire, I think that it's, our job, it's an overall, job from all of us to try to detect those patients that can benefit from the therapy, because I'm pretty sure that, it's going to be much more than this, 2% of people. So if we're talking about expanding, the indications for LAO, so we need to go back to the past, because in the past, we can see that, most of the studies were focused on patients that were intolerant to oral anticoagulants, at least, at long term. And in a sense, they had a problem. They had a problem with the anticoagulants. Now, it seems that we are moving, just more, at least with the studies, to a field, with patients that can tolerate. Actually, we want to compare, more than, just go against. It's just compare two oral anticoagulants to see, which therapy can be better or not. And there's also another type of population that actually they also have a problem, that they're tolerant, but the action of these oral anticoagulants, it's not enough. So it's not that they cannot take oral anticoagulants, it's that the oral anticoagulants are not enough for them because they present, stroke or embolization. And that's, in a sense, that would sum up because actually, that, it's the whole picture, because sometimes, of course, you can have, a patient, on the right side with a high bleeding risk, but in a sense, it's more or less this, the first patients had or have, a high, bleeding risk, and the patients on the right side had, or have a high stroke risk. So what's the evidence? So the evidence, as I said, in the past, and something that has already, been published, like studies, like great studies, with a lot of patients, like Pinnacle Flex, with Watchman Flex, showing, that, the very good outcomes with this device, also the Amulet ID. And I would say, just to be, kind of novel, now, the main focus of these studies are on maybe new devices, but also antithrombotic therapy. So we'll talk about Simplify, Andes, and also Adala. Then in the mid part, as I said, we have, studies where we compare with patients that actually can take oral anticoagulants or DOAC, direct oral anticoagulants. Surprisingly, one of the first studies that did was PROTECT-IF from more than, 10 years, actually, was assessing patients that were eligible, for this type of therapy or anticoagulation, and they saw very good outcomes. So, I mean, it's something that we already have some evidence. And then we have PREC M14, I would say that it's really innovative, and it's more than 7 years since it was, published or start. And then, of course, like Maret said, of the option trial, we'll talk about Champion, Catalyst. And on the right side, for those patients with, high risk of a stroke and in which, or in whom oral anticoagulants are not enough. So we have LAAOS IV, LAAO, and LAAPS. So let's move forward. When we talk about antithrombotic strategies, we need to think that, or why we're giving antithrombotic. So we're giving antithrombotic because we want to prevent DRT, device-related thrombosis, or other, ischemic events like a stroke or TIA. But also, we always need to think that, those patients, at least, for till now, they have a potential risk of bleeding. So when we talk about weak strategies, we're saying that SAP, aspirin, or even low-dose DOAC. When we're talking about current, or I would say, standard therapies, we're talking more about DAPT or oral anticoagulant, or even DOAC. And when we're talking about intense, those patients, with high risk, LAAOS IV and LAAPS, these patients, and we're talking about intense antithrombotic therapy, it's oral anticoagulant plus sometimes something else like Adiro, or even like DAPT. So, as we said, the first study that was published last year, that was the Adala trial with only 90 patients, but with the first study that actually was randomized and show that half of DOAC, and specifically apixaban 2.5 twice a day, was superior to dual antiplatelet therapy in terms of preventing the composite endpoint of hemorrhagic events and thrombotic events, including DRT. So that actually opened a door to the future, because maybe, the standard therapy that it has been for many years, that maybe it's not that good. Okay, maybe it's associated with some thrombotic events, and maybe it's also associated with not enough efficiency in terms of efficacy for preventing DRT or even stroke. Then we have, I think, that a very interesting study that it's going on with Watchman Flex Pro, in which we will have 3 arms. After implanting a Watchman Flex Pro in more than 1,500 patients, patients will be randomized to aspirin, half-dose DOAC, or the standard DAT. And we will see at 6 months and 12 months what's going to happen. And then another study that it's very similar to ADALA, but with more than 500 patients that actually 2 weeks ago finished the recruitment. I think that the results are going to be presented at TCT this year. So it's the same. So after a successful LAA occlusion, so patients are randomized to DOAC, the first half, and then half-dose DOAC for the second half, and the other half to standard therapy of that. So they are followed with standard imaging techniques and, of course, clinically, and we will see what's going to happen. And then we move to this, I would say like mid area of patients that can take oral anticoagulants, but we will see, if LAA can compete, with DOAC or OAC. And as I mentioned, we start with Protect AF, and then we move to PRAC, because PRAC already compared the therapy with direct oral anticoagulants, and it was very brave. It's true, it was more than 400 patients, small maybe sample, and with a high risk of stroke, it's almost CHA2DS2-VASc of 5 and a Hasbled of 3.1. But interestingly, in terms of efficacy, there was no difference. So I mean, the therapy, the occlusion of the appendage, was as good in terms of efficacy as DOAC for preventing strokes and embolisms. And when we postpone this follow-up, that efficacy persists, meaning that there's no difference, in terms of a stroke or TIA. But if we go, to the bleedings, those patients, that are, in the medical arm, they keep on, oral anticoagulants, they keep on bleeding, whereas patients on the left atrial appendage arm, they're not bleeding. So I mean, there is a superiority in terms of bleeding, and the efficacy is prevented. So it's like really promising data for future trials, as we will see. And then, of course, I'm not going to talk, but I wanted to mention, because this is probably one of the most important trials that has been published in the last year, the option trial. But I mean, Marek has, just talked very comprehensively. And then I want to move to Champion, that it will be a key trial for the future. Now we want to know if left atrial appendage occlusion is as good as oral anticoagulants, as direct oral anticoagulants, as the current practice. So in more than 3,000 patients that have already been included, now are in the follow-up period. So we want to see if a Watchman Flex is non-inferior for stroke, cardiovascular death, or systemic embolism at 3 years. So the follow-up will be 3 years for presenting, the main results. Then there is an endpoint of superiority for bleedings as well at 3 years, and another endpoint of non-inferiority for the occurrence of ischemic stroke and systemic embolism at 60 months. That means 5 years. So that would be more or less the sequence, the diagram of the study. Where you can see that, of course, patients with DOAC, they keep on, the drug, and patients with the Watchman Flex, okay, after 3 months, they stop DOAC and aspirin, or just DOAC alone, or DAT, and they, keep on aspirin for, the long run. We also have Catalyst, that it's with the AMLET. It's less patients, 2,650 patients. Randomization, it's almost done. I would say that it's 150 patients still to go. And actually the endpoints are pretty much the same, no? So a composite of ischemic stroke, embolization, and cardiovascular mortality, a superiority endpoint of major bleeding or clinically relevant non-major bleeding, and a composite of ischemic stroke or systemic embolism throughout 3 years. So it's more or less same design than Champion. And then we move on, to the last part of these studies, that it's, patients with extremely high risk of stroke. And then we have the one of the most important studies, that is the LAAOS IV, trying to include 4,000 patients. I mean, it's really worth mentioning. It's 4,000 patients. It's a big effort from the company in a 1:1 randomization. So they will compare the oral anticoagulant versus oral anticoagulant plus the therapy, plus Watchman Flex. And we will see, like a high-risk population. So the primary efficacy outcome is the first occurrence of ischemic stroke, systemic embolisms, and strokes of undetermined etiology will be treated as ischemic strokes. And who's going to be appropriate? So patients, as that are considered high risk, patients with permanent or persistent AF, with a history of ischemic stroke or systemic embolism, patients with high CHA2DS2-VASc, 4 or more, or increased risk of a stroke, and patients that can take oral anticoagulants. So we don't want patients with bleeding risk because those patients cannot be compared. So that study will provide a lot of information in this very high risk population. And then we have two very similar studies. That one is the LAAO with patients that focus on subjects that have already experienced a stroke despite oral anticoagulant, and of course that they have a left atrial appendage suitable for closure. So randomized to, again, appendage closure plus DOAC versus best medical treatment. So these patients will be followed up to 1 year, and then with a very similar but more patients, it's the LAAC trial. It's 242 per arm, exactly or almost exactly the same design. So we will see, those patients that, present with a stroke, despite oral anticoagulant, if they do better, implementing a second line of security, like the appendage closure, or how they do with medical treatment. So that was it. Thank you.
Xavi, thank you very much. I think that it was a nice overview of everything which will be in the future. However, I have just one question, and I ask you for a short answer. I think for me, the most important trials are the Option, Champion, and Catalyst. What is your opinion? Will these, if these trials will be positive, will that change the current guidelines, ESC guidelines in Europe? What is your prediction?
That will be, like a mess. I think that they're going to play two main factors. One, it's going to be the patient's preference. I think that this is going to be a very powerful arm, because if patients can choose, I mean, that, make, the difference, the global difference. But also, of course, there's going to be the reimbursement issues of every single national health system. I'm not very optimistic in that sense. I'm sure that if those like politicians will see the long term of a lifetime I would say evidence of problems with the DOAC paying for every single month medication, and also adding the cost of the complications with the oral anticoagulation versus 1 single day with intervention, that it's a same day discharge intervention. I think that if they compare at the long term, there's going to be a big difference. So maybe in that sense, all the studies about, efficiency and cost effectiveness, I think that they're going to be very important. But I think definitely if they're positive, they're going to change the landscape of the therapy.
Yeah, Xavier. I mean, indeed, that's then about Champion AF. That's going to be a breakthrough if that trial indeed shows non-inferiority, I think. But it's also interesting to discuss on, I want to hear how you do in your clinic. We all agree that if you have you have these two ends of the spectrum, high bleeding risk, high stroke risk. We all agree that those with a very high bleeding risk, we can really treat them and offer them a benefit to close their appendage and then remove their anticoagulation. But what do you do nowadays in your practice? If you get, do you accept referrals, for example, from patients who have breakthrough stroke despite oral anticoagulation? Do you offer them LAA closure already? Or do you say, no, I want to wait for LAAOS IV and any LAAPS or LAA at the studies?
Well, it's a very good question and also a very difficult question. I think that there is a nice registry, a large registry from the Netherlands group, from Dr. Boresma, showing that patients, that profile of patients, stroke despite oral anticoagulant, they do better with like the dual therapy, oral anticoagulants and LAA occlusion. We know that with the medical treatment, the recurrence of stroke, it's up to 15% in 18 months. So it's extremely high. So I would say that we don't have the evidence. I mean, if we have the opportunity to participate in these trials, we have to participate. But the evidence, it's very close. So I would offer the therapy. In a sense, it's like saying that, in type A aortic dissection, we need a randomized trial because, there is no evidence. There is no randomized trials. You have to treat the patient because you know that the outcomes, if you don't treat, are going to be bad. So in a sense, I would say that it's kind of a similar situation.
Thank you, Xavi, and thank you all. I think now it's time to conclude. And I think the key message from today, what we wanted to discuss with you all, is that after a first, I would say, initial period, we have had a fantastic decade with this landscape of left atrial appendage closure. So we have more and more evidence. We have a nice, and Ole, you showed that, a very, very important experience with imaging, and imaging has completely changed the field about how to do with the procedure, how to plan the procedure, how to follow up the procedure. We have also a very nice input from, I would say, the devices with great innovations for the last decade. And now I would say at the moment we are proud to say that the procedure is efficient in our patients and it's very safe. And it's very safe. And this is something very important. So we are proud to say, okay, now we say the procedure is efficient. If your patient needs, you can refer your patient. We will treat the patient and it will be okay for years. And I don't know, but for me, the next decade, the coming decade, will be the decade of expanding indications. And we all showed about trials, and we know that this is something that will come with the trials. Option, that is a new trial, recently published, but all the trials that Xavi presented, and I'm sure, and I think we want to push with Xavi, and I'm a little bit more optimistic that with this evidence we will have better guidelines and potentially better reimbursement. So first of all, thank you all the speakers. You are great experts and you did great today, so thank you. I would also like to thank Boston Scientific who supported this event and the team here for PCR webinar in the studio. Thank you for all your help and assistance. You were really great and we really appreciate. And we hope to see you soon. Thank you again and see you soon. Bye-bye.
Yeah.
Bye-bye.
Yeah,
Thank you.
bye-bye. Thank you.